Hello, everyone. My name is Mohammad Ibrahim. I am currently a fellow physician at the University of Michigan Health West. So good evening and welcome to tonight's Journal Club meeting. I'll be serving as the club advisor, moderating tonight's Journal Club meeting. The goal of this Journal Club, the AMSSM Journal Club, is to provide a national platform for students and residents in AMSSM to present an article from the list of the top 120 articles that every sports medicine fellow should be familiar with. And the intention is to make this a fun learning experience to give the medical students and the residents mentoring opportunities with other AMSSM members while developing skills of reviewing articles and making PowerPoint presentations. Tonight, we have a special treat. We have 3 presentations. The format of the Journal Club meeting is that each presenter will have about 20 minutes, give or take, and it will include a brief Q&A segment after their presentation. If you do have questions, please enter your questions using the chat function, and during the Q&A session, I will call on you or I will read your question out loud to the presenter. It's my honor and I'm pleased to introduce our first speaker and our first presenter tonight, Dr. Young Hugh, and his club mentor, Dr. Derek Stokes. Dr. Hugh is a PGY2 family medicine resident at Stanford Hospital, Columbia University in Connecticut, with a lifelong passion for organized sports. As an avid gym goer and a runner, his personal experience with sports related injuries sparked a strong interest in sports medicine. He's dedicated to helping individuals recover from musculoskeletal conditions, guiding them back to their optimal health and functional baseline. His presentation is on the article, Acute Foot and Ankle Injuries and Time Return to Sport. I would also like to thank Dr. Derek Stokes for serving as his club mentor. Dr. Stokes is an assistant professor of physical medicine and rehabilitation and sports medicine faculty at the University of Colorado in Aurora, Colorado. His interests include sports ultrasound, injury prevention, and medical education. And without further ado, Dr. Hugh, you can share your screen and start your presentation. You're good to go.
Okay. All right. Yeah, so I'll just get started. So, because I want to be mindful of our time. So I'll be talking about acute foot and ankle injuries and return to sport. So just kind of a basic content outline. We'll go over some background, and then we'll kind of go through each individual foot injury. The 5 most common that these authors selected were Liz Frank, turf toe, deltoid ligament, which is associated with syndesmosis injuries, and then proximal fifth metatarsal fractures. Then we'll kind of just discuss very briefly about their discussion and conclusions. I'll finish with my references and then open up to any questions. So just some background, foot and ankle injuries are commonly injured in athletes and active individuals. These injuries can appear on a very large spectrum, which range from sprains to career-ending injuries for professionals. So that's why accurate diagnosis and early treatment is paramount to getting these athletes back on the field, and is gold standard treatment for these kinds of injuries. So today we'll discuss the 5 most common, looking through their anatomy, exam, diagnosis, staging, and then ultimately treatment and return to play. So starting off with Liz Frank injuries, kind of going through the anatomy, it's the articulation between the metatarsal and tarsal bones, as you can see here. The ligament, like the Liz Frank ligament itself, is right here, and it connects the medial cuneiform to the second metatarsal bone there. And it is an important stabilizer in the foot because, as you can see, if this ligament gives out, then it kind of gives instability to this entire joint line there. In terms of the mechanism of injury,
is it? Yes.
Go ahead.
Good story to tell? Not really. It's
Hello?
I think I did.
Oh, okay. Yeah, so in terms of the actual injury, it's you have 2 different ways of getting injured in this way. You have the direct injury and indirect. In terms of direct forces, it's mainly crushing injuries. So mainly has to be something pretty heavy, whether it's a weight or like a vehicle. Can also be like a heavier athlete stepping on that joint. But the more common injury to the Lisfranc area is more so indirect injuries, which is like an abduction and plantar flexion. And they often occur when the forefoot's in like abduction, plantar flexion, and then that causes the TMT joint to have a lot of stress on it. In terms of the physical exam, you'll have, and all my physical exams are kind of going to go through the same process where you have inspection, palpation, motion, and then kind of going through gait and special tests. So for the Lisfranc injury, you'll kind of look at the injury first. You might see some ecchymosis, swelling, tenderness to the general area. You'll look through and kind of see their active, passive range of motion and go through instability testing. Essentially, the instability testing is very similar to some of the special tests as well, where you will kind of grasp the metatarsal heads and apply like a dorsal force to it, while your other hand palpates the TMT joints. Any kind of laxity kind of suggests that there may be instability. And then also looking at like the first and second metatarsals, they could be displaced medially or laterally. That also suggests instability and more likely a need for surgery. I'm going to go just very briefly through these special tests, but again, they're very similar. Like the piano key and provocative tests are more so just kind of translating that joint up and down, seeing if there's laxity. Piano key is just different in that it targets the second metatarsal, whereas the provocative test targets all of the metatarsal joints there. And then you have the single limb heel raise. This one's a little different in that it tests for more subtle Lisfranc injuries. This one, you just have the athlete go up on their tippy toes. And usually if someone has a Lisfranc injury, that will cause pain. So it's a good way to elicit more subtle Lisfranc injuries. And then Lisfranc injuries in terms of grading are different in terms of like ligamentous injuries. Usually for like ligamentous injuries, and we'll see with some of the other tests or grading, it's usually one is kind of a stretching of the ligament, two is more of like a partial tear, and three is usually a full thickness tear. But that's different for Lisfranc injuries, and Nunley and Vertillo actually wrote about this in their paper, and this is actually the image straight from the journal article. So stage one is just a ligament sprain, kind of like a stretching of that ligament, so no tear. And then stage two and stage three are both tears or ruptures of the ligament, and they also have 2 to 5 millimeters of diastasis. The only difference between two and three is that stage two does not have any arch or height loss, whereas stage three will have that height loss. And then, there is utility in pursuing MRI, especially when your diagnosis is in doubt between stage one and stage two, just because the management is completely different for those types of injuries. Here is just a radiograph image of this injury. So most of the times, you'll get an imaging just to make sure there's no fracture. But here you can kind of see that the Lisfranc ligament would be sitting here. Obviously, you won't be seen on X-ray, but you can see that there's a green line going through showing that there's no diastasis between the first and second metatarsals there. And then here is the Lisfranc injury, where you obviously won't see the Lisfranc ligament. It's been ruptured. You have this red line, which is not even, and you can see there's diastasis here, showing that there is likely instability of this area. And then going on to treatments, so this is why it was important to kind of give that MRI before if you weren't sure. The kind of line is between stage one and stage two and three. Stage one, you don't require any surgical intervention, just immobilization and restricted weight bearing. In particular, in terms of the immobilization, you'll be using a fiberglass cast for 6 weeks. Then at 6 weeks, you'll see if the patient's pain-free. If they are, you can advance them to an orthosis, and then have them have a specific sport return to play. But if they still have pain after removal of that initial fiberglass cast, then you have to put them in a ankle foot orthotic for 4 weeks and then have them come back and see how they're doing after that. On the contrast for stage two and three, like I said, there was that ligamentous tear and there's that diastasis. So you do need surgical intervention. The main difference is that, you can get a CT to kind of see if there is any need for a fusion versus an open reduction internal fixation. And there's utility in getting that kind of extra imaging. In terms of return to play, a lot of times these injuries can be career-ending if it's not diagnosed correctly and treated correctly. So that's very important. But even then, there does have to be some expectation counseling for the patient in terms of re-injuring the area. Okay, so moving on to our second injury, turf toe injuries. This is a ligamentous injury to the hallux MTP complex, which is also known as like the turf toe area. Usually, in terms of management, you want aggressive rehab and kind of early return. And studies have shown that there is no like compromise in terms of going back to play. And in terms of mechanism of this injury, you can kind of see it here in this picture, but it's plantar flexion at the ankle. And then MTP joint is like dorsiflex. So you kind of cause stress in this area of the toe. And in terms of grading, this is what I was talking about in terms of ligamentous injuries. Usually you'll have grade 1, which is stretching. Grade 2 is partial tear. Grade 3 is that complete tear. All right, now in terms of the actual physical exam, kind of same thing as the last one. You'll kind of inspect the area first, look for any swelling, ecchymosis, look for alignment of the hallux itself. In terms of motion, you want to see them active range of motion. If they can't do that, go ahead and try passive. Usually they won't be able to hyperextend the joint because they'll have pain or symptoms. And then you also want to just check for varus and valgus instability. In terms of testing this for special tests, there is really just this test here, which is the vertical Lachman test. Essentially, you're grasping the metatarsal head with one hand at the base and the proximal phalanx in the other, and kind of just agitating it up and down in terms of translating and seeing how well it translates up and down. You'll compare that to the unaffected toe and kind of see if there is more laxity compared to the other one. And then you also look at gait as well, just to make sure that they're able to walk fine. I was going to go more into detail with these MRIs, but just for the sake of time, the top ones are normal MRI findings, whereas the bottom ones are abnormal. So for the top, you can kind of see a clear tendon coming through here. There's no ecchymosis, there's no swelling. Here we kind of see the attachment, a little recess that is normal for the insertion at the plantar plate. Whereas these abnormal MRIs, you can kind of see here, there's some edema, there's some swelling around like the joint there. And then you can also see some fluid where the arrows are at, showing something abnormal on the testing. In terms of treatment, you have grade 1, which is just a minor stretch injury. These are a pretty short course of treatment and consist of taping, which you can see here, just taping the foot to prevent any dorsiflexion. In addition, you can kind of use these metal or carbon fiber plates to help prevent the foot from going into dorsiflexion while you're walking. This is a Morton extension, kind of just targets your big toe, whereas this is your entire foot. In terms of grade 2 tears, you do have partial, disruption injuries. They do recommend early passive range of motion, but you do have to be in a boot as well to help kind of protect the foot in that cast. Once once that's kind of stabilized, you can kind of get downgraded to the grade 1 where you continue with the taping and the foot plates for stability before you return to play. And then for grade 3, with the complete rupture, you do need surgical intervention, especially on imaging if you see like proximal migration of your sesamoids. All right, so the next type of injury is a deltoid ligament injury. There's deep and superficial portions to it, and I'm not going to go too deep into the anatomy there. But essentially, a good thing to remember is that the tibio-navicular, tibiospring, and deep posterior tibial involvement are important because those are present on everyone's anatomy. So those are usually involved in deltoid injuries. And the deltoid is also important because it is related to the syndesmosis between the tibia and the fibula. So those kind of come hand in hand in terms of injuries. And then mechanism of these deltoid ligament injuries are just high energy eversion ankle injuries. And I'll show you in like 2 slides. I have a pretty good image of that. But yeah, usually high energy in terms of eversion. The physical exam is also pretty straightforward. You're looking at inspection, so you're looking at ecchymosis, swelling, tenderness to palpation of the medial malleolus there. You can look at motion, so decreased range of motion most likely in that foot, secondary to swelling and pain, and you can compare that to the other side that is not affected. The special test for this deltoid ligament is really just kind of a Taylor tilt test. The Taylor tilt itself is more so looking at all of the ligaments of the ankle, but this in particular looking at eversion stress test. So you can kind of see here they're twisting the ankle and putting stress in this area to see if there is any laxity. And then also you want to kind of look at gait because thinking about Ottawa's rules where you're likely to get imaging anyway, but also just making sure they're able to have a gait. So this is the image I was talking about in terms of like the high stress eversion injury right here. And then grading, similar to all kind of ligamentous injuries. Grade 1 is just a stretching. Grade 2 has that partial tear. Grade 3 has that complete tear. The authors of this article did say that there's controversy regarding like a surgical repair, especially with syndesmotic disruptions. But they say that there really is no high quality evidence going either way of conservative versus surgical repair. So that's something to note. But mainly kind of going through the treatments of deltoid ligament injuries, the mainstay of treatment is immobilization. So similar to other strains, immobilization, making sure that you're not moving through the injury. And then the timing in terms of the actual time in a boot depends on the severity of the injury. So like grade 1, 2, or 3. And then kind of related to the deltoid injury, you have the syndesmosis injury. So the tibiofibular syndesmosis joins the fibula to the tibia, and it has 4 lateral ligaments. The AITFL, the anterior inferior tibiofibular, the interosseous, which is right here, the posterior or PITFL, and then the transverse ligament right here. In terms of the actual mechanism here, usually is an excessive external rotation of that ankle. And again, kind of can be also high force injury because it's related to that deltoid ligament, which does also provide stability to the syndesmosis. So very briefly here, kind of just going through the grading classification. This one's also different from your usual ligament injuries. So it's important to note for all syndesmotic injuries, it involves the AITFL. For the grading, you have partial tear of the syndesmosis for grade 1. There is no signs of diastasis on imaging. It's considered a stable injury. And really kind of management depends on that syndesmosis. For type 2, it's kind of known as like a latently unstable injury because you do have no diastasis on non-stress imaging, but on stress imaging, when you're placing stress on that syndesmotic joint, there will be some diastasis. So if it's not treated properly, it could become unstable. And then for the type 3 injury, you have a complete syndesmotic disruption with diastasis on static imaging. And this usually also involves like concomitant like fractures as well as a complete deltoid ligament rupture. So kind of like a very high force injury causing those type 3 syndesmotic injuries. In terms of diagnosis, again, inspection, palpation, motion, gait, those are kind of things just to all look for all of your MSK exams. But in terms of special exams, I'll kind of go through the squeeze tests, which is shown right here in this image. So you'll essentially just squeeze the tibia fibula together, starting more proximally and then going down towards the ankle. And the sign for this study is that the higher up the patient starts feeling pain, generally shows like a more severe injury. And then here on the bottom here, we have a cotton test. The physician here is kind of stabilizing the tibia and fibula and then causing a lateral translation. And then seeing if there's like 3 to 5 millimeters of translation, or if you feel a clunk, that's generally a positive test. And the last one is this fibular translation test where you are stabilizing the ankle joint there and then grabbing the fibula and kind of translating it anterior posterior. And then you kind of compare that to the other side as well. And if you see anterior posterior laxity in the affected joint, that is generally a positive test. And then just kind of these, imaging is important for these types of injuries, again, for the diastasis. And then there are also, articles showing that you can do functional tests under anesthesia, but I do believe that's pretty rare. So treatment wise, usually this is split between grade 1, 2, and then grade 3. Grade 1 and 2 generally can be, immobilization in a boot and rehab. And then return to play is usually in 13.4 weeks. And then for grade 3 injuries, they can be managed conservatively and have good outcomes, but a lot of research has also shown that return to play was faster within the surgical group. And then here's just kind of an intra-op image where they did the fixation of the actual fibula, but you can kind of see there's diastasis there. This, I'm not going to go too much into detail. The authors just kind of added this chart as a way to kind of go through systematically how you should work up a patient. But again, I kind of talked through all of this in the previous slides, but it is useful as you're going through and diagnosing patients with this injury. I'm going to not spend too much time on this slide as well. This is just kind of stating that when the patient requires surgical fixation, surgeons had preferred flexible devices, but the authors say that there's not really any rehab and discharge protocols, so there needs to be more research into that area. All right, so our last injury is the proximal fifth metatarsal or Jones fracture. So this is a fracture to the proximal metadiaphysis that extends into zone 2, which is right here. And that's not to be confused with a stress fracture, which of the proximal diaphysis, which is in zone 3. The main thing I would just want you guys to remember is that this is like a watershed area, so very poor blood supply, and these wounds don't usually heal too well. And then the mechanism of injury is usually just very repetitive weight bearing and pivoting on this affected area. And I'll kind of talk about it on the exam. There's certain things that predispose patients to kind of like these fractures. And then very briefly, this is just a radiographic, radiographs showing kind of the zones. So zone 1, zone 2, zone 3. You can kind of see the tendons where they attach in this area. And then here in this picture, you kind of see that fracture right there. In terms of the proximal fifth fracture, same thing, inspection palpation. You may see some rare skin tenting in zone 1 fractures. And then you'll have tenderness at the palpation site. These are kind of anatomic things that predispose people to these types of fractures. So the cavus foot deformity up here, where they're placing more stress on the metatarsal area. And then you have the varus hind foot alignment here, where again, you're kind of placing more stress in these areas. And then in terms of motion, you want to see, their range of motion, their gait, very similar. Special tests, not really for this exam, but there is pain with resisted foot eversion. And the reason for that is it kind of indicates peroneal tendon weakness, which if we kind of go back to this image, you can kind of see that it attaches generally kind of to this general area. All right, so in terms of treatment, there is weaker evidence for a higher rate union in operative versus non-operative in acute fractures, but there is stronger evidence favoring open reduction internal fixation for delayed and non-union, so that you should definitely go for that if that is the case. And ultimately, there is a low threshold to treat athletes. Even then, though, there is a prevalence of refracture in about 4 to 12% of athletes. Main goal here is to expedite healing and then enable rapid rehab to kind of decrease the refracture risk. All right, and then almost done here. This is just a operative protocol that the authors came up with, but it's by no means a gold standard. So kind of having a bone stimulator, vitamin D, you have 2 weeks non-weight bearing, 4 weeks weight bearing. You can start running at 6 weeks, return to sport at 8 to 10 weeks, and then kind of like an insole that can help with the recovery. And then you can get a CT if you're having ongoing pain. The main I guess, forced driving the sport return to sport at around 10 weeks is that there was an NFL return to play protocol that showed that, athletes that returned greater to the 10 weeks had decreased refracture risk, whereas less than 10 weeks had higher refracture. All right. So lastly, just kind of the discussion conclusions, just closing up. There's not really any gold standard in terms of return to play, and that makes sense because each sport has very different needs. There are some sport-specific scales that I have listed here, but again, they're not specific to just athletes. They can be for like recreational athletes as well. And ultimately, there is a consideration that a lot of like elite athletes have more access to healthcare in terms of like physical therapists, trainers, athletic trainers, kind of more access to those types of resources, whereas recreational athletes may not, and therefore their recovery times may be higher. And ultimately, for all kind of musculoskeletal injuries, you do have to make a accurate diagnosis and early treatment, and that is gold standard across the board. Here are just some references I used, image references, and that's it. Thank you. Are there any questions?
Thank you, Dr. Hugh, for that presentation. What an excellent overview on foot and ankle injuries, and return to the sport. Before moving on to question and answers, I did want to give the club mentor, Dr. Stokes, an opportunity to share maybe one pearl or comment about the topic, if you have any, Dr. Stokes.
Yeah, I think first of all, great job, Andy, as kind of summarizing that review article. There were a lot of obviously different topics and different areas of the foot and ankle to review, so good job with that. I think one thing that I picked up from the article was they talked about very specific grading scales and imaging findings and things like that. And there's many of them within the literature. So we kind of have to pick and choose about which ones we're going to memorize, which ones we're going to utilize. So I think that's a lot of institutional preference and just kind of cozying up with your radiologists and your surgeons and whoever else, just to kind of know that you're speaking the same language with those grading scales and different imaging findings.
Thank you. I think one of the things that stood out to me was just really learning about the syndesmotic injuries a little more and how, clinically relevant that is. So things I wish I knew when I was a resident, right? Thank you, Dr. Hugh, and thank you, Dr. Stokes.
Just a quick question.
Yeah, go for it.
I took the sports medicine boards back in 2000, 2010, and 2020, and I can't emphasize this enough. This article is the typical stuff that they ask on the sports medicine boards. Probably 90% of the information is about musculoskeletal, and they love fifth metatarsal fracture questions, and they heavily tried to distinguish the three, for example. And so, really focus on these musculoskeletal. There's a lot of medical stuff on the boards, but the focus of the boards is these types of injuries. And this article in itself has multiple potential questions. They don't typically ask about grading and staging. They want to know if you can make the diagnosis, whether it's an avulsion of the fifth metatarsal versus the Jones. And so that's kind of the key of the test, being able to diagnose these problems.
Thank you. That's very helpful. I would like to introduce our second speaker tonight, our second presenter, and that's Dr. Jasbir Singh and his club mentor, Dr. Mark Troxler. Dr. Singh is a PGY3 internal medicine resident at NYU Long Island Community Hospital. Sports medicine aligns with both his professional and his personal interests. Having participated in various sports such as basketball, soccer, and football, he has firsthand experience with significant injuries. These encounters have provided him with valuable insight into the patient perspective regarding treatment and rehabilitation. Recently, Dr. Singh has begun boxing training in pursuit of returning to competitive sports. His presentation is on the article, Athletic Pubalgia, or what we commonly know as a sports hernia. I'd also like to thank Dr. Mark Troxler for serving as his club mentor. Dr. Troxler is in private practice at McKinney Internal Medicine and Sports Medicine in McKinney, Texas. He is the chairman of Anti-Doping Education Committee for USA Track and Field. He has also served as team physician for youth, high school, college, Olympic, and professional athletes. He completed medical school at Oklahoma State University College of Osteopathic Medicine in Tulsa, Oklahoma, and completed his internship year of residency at Hillcrest Health Center in Oklahoma City, Oklahoma, and his internal medicine residency at University of Oklahoma College of Medicine at the Tulsa campus. Dr. Troxler completed his sports medicine fellowship at Jersey Shore University Medical Center and Rutgers in Neptune, New Jersey, and he also received an MBA degree at University of Massachusetts Amherst campus. So without further ado, I'd like to turn it over to Dr. Singh so we can tune in to his presentation.
Thank you, Dr. Ibrahim. Really appreciate the introduction, and I want to thank Dr. Troxler for his mentorship as well. So I'm just going to go ahead and share my screen here.
You are good to go.
Okay, excellent. So I'm going to speak about athletic pubalgia, and this is based out of an article in Clinics in Sports Medicine from April 2011. Some of the objectives that I'm going to touch upon are the definition. I'm going to dive into the historical context of this disease, look at that epidemiology, the signs and symptoms that we see, the physical exam, imaging, differential diagnosis, and then conclude with a treatment. So by definition, we have sports hernias or any condition causing persistent pain in the groin without a demonstrable, sorry, just 1 second here. Without a demonstrable hernia. This assumes that no other significant GI or genitourinary condition is present that might account for the patient's symptoms. So historical context, in 1980, Gilmore started to surgically repair a syndrome of chronic lower abdomen and groin pain in athletes, with the majority of these being soccer players. Around the same time in Europe, Taylor and his colleagues began to notice and study athletes in which they found abnormalities of the abdominal wall in the groin region, including palpable hernias, non-palpable hernias, and microscopic tears or avulsions of the internal oblique muscles. So two major philosophies emerged. One, the concept of muscular injury and disruption that was popularized by Gilmore. So it's also popularly known as Gilmore's hernia. So athletes in Gilmore's study were found to have a torn external oblique aponeurosis causing dilatation of the superficial inguinal ring, a torn conjoint tendon or dissonance between the inguinal ligament and the torn conjoint tendon. So this is a picture just sort of showing the aponeurotic fibers of the external oblique and then the boundaries of the inguinal canal. So here we have the superficial inguinal ring and the deep inguinal ring. And the most important aspect of this is actually the posterior wall, which is formed by the transversalis fascia laterally and the conjoint tendon medially. So the conjoint tendon here is made up of the transversus muscle as well as the internal oblique muscle, and then it conjoins right here, the medial aspect. So Taylor and his colleagues coined a term called pubalgia. So they said a groin pain most commonly caused by muscular tendinous strains of the adductors and other muscles crossing the hip joint, but also related to abdominal wall abnormalities. In addition, they added, cases may be termed pubalgia if physical examination does not reveal an inguinal hernia and there's an absence of other etiology for lower abdomen and groin pain. In addition to this, there was another group led by Mayer who added that the injury is caused by hyperextension mechanism. So here you can sort of see that the rectus abdominis origin is sort of pulling one way, whereas the adductor longus is pulling another way. So putting it all together, all the authors of this paper, including all the philosophers, believe that a large tear or multiple micro tears take place that involve one or more muscles in the region, which include the external oblique aponeurosis, the rectus abdominis, and the conjoint tendon rectus abdominis interface. So just sort of looking here, we can see the conjoint tendon here, the rectus abdominis, the external oblique. and the pubic aponeurosis occurring right here, and the adductor longus here distally. So who's really affected here? It's usually seen more common in athletes who are involved with running, kicking, cutting movements, explosive turns, and changes in direction. So some of the major sports that we really see it in include rugby, Australian rules football, ice hockey, American football, cricket, martial arts, basketball, baseball, field hockey, and tennis, amongst others. So looking at the epidemiology, it's definitely more common in men. At the time of this when the article was written, which was 2011, women represented 15.2% of all cases. And there's a likely reason for this. So men tend to have stronger muscles in the lower abdomen and groin, which isn't always the case, but in most cases it is. In women, the gynecoid pelvis actually provides a greater span of muscle insertion along the pubis and ilioinguinal ligament and distributes forces along a greater surface area. So here you can see the gynecoid pelvis in females and the android pelvis in males. So the gynecoid pelvis, you can see it's wider and broader, and there's less prominent ischial spines. So what are some of the signs and symptoms? Touchingway and Grich basically describe 5 signs and symptoms that are most indicative of a sports hernia. So one is a subjective complaint of deep groin or lower abdominal pain. 2, pain that is exacerbated with a sport-specific activity such as sprinting, kicking, cutting, and/or sit-ups, which are all relieved with rest. 3, palpable tenderness over the pubic ramus. 4, pain with resisted hip abduction at 0 or 45-degree angle and/or 90 degrees of hip flexion. And then lastly, pain with resisted abdominal curl-up. In addition, in the early stages, pain is usually felt like later on in the activity or near the end of the activity. As the condition worsens, pain becomes more severe and starts to occur earlier and earlier in the activity. Pain is usually relieved with rest but returns on resumption of physical activity. It's usually unilateral, but the pain may radiate to the uninvolved side or the scrotum. So for the physical exam, we need 3 out of the following 5 signs to diagnose a sports hernia. 1 is pinpoint tenderness of the pubic tubercle at the conjoint tendon insertion. 2, tenderness over the deep inguinal ring. 3, pain and/or dilatation of the external ring without a palpable hernia. 4, pain at the origin of the adductor longus tendon. And finally, dull or diffuse groin pain that often radiates to the perineum and inner thigh or across the midline. And we definitely want to eliminate other causes of groin pain, which could be due to hip adductor origin tenderness, and pain with resisted adduction suggests an adductor-related groin pain. Tenderness at the pubic symphysis, which indicates pubic-related groin pain. Pain with resisted hip flexion and/or stretching of hip flexors suggests iliopsoas-related groin pain. Hip joint-related groin pain during Fader and Faber tests. And we want to rule out genitourinary etiology. So here we sort of look at some of the adductors, including the adductor longus, the gracilis, adductor brevis, and the adductor magnus. So in terms of imaging, two imaging tools are used. One's MRI and one is ultrasound. However, irrespective of the abdominal wall findings on an MRI, a patient with a typical history and physical examination and no other injury may be a candidate for repair. However, MRI is helpful as it may diagnose other causes of pain, such as strains, labral tears, osteitis pubis, iliopsoas bursitis, and occult stress fractures. Then we have dynamic ultrasound. So this is used to establish posterior inguinal wall deficiency. So a probe is basically placed over the medial aspect of the inguinal region, and the athlete is asked to strain. It's considered positive if there's abnormal ballooning of the posterior inguinal wall. So here we have a short axis view. So the top here is the left side, and the bottom is a right side. So this is, and the left side of the screen is a normal picture, whereas the right side is actually an abnormal picture. So On straining, you can sort of see here the red marking here is a posterior wall of the inguinal canal. And normally it should be concave on straining. However, in sports hernias, you can see that it's actually convex or ballooning. It's seen more on the left side than the right. So while there are many differential diagnoses of growing pains, and I'm not going to go into each one of them, they're sort of split up into inflammatory, which can include inflammatory bowel disease and endometriosis, PID, then broken up into musculoskeletal, which includes many, including our sports hernia and stress fractures and muscle strains. Infectious etiologies or differentials can include osteomyelitis, prostatitis, epididymitis, and then neurological, which can include nerve entrapment. Going to neoplastic testicular cancer is one that sticks out, and then others as well. So in terms of treatment, we like to look at it through two lenses. One is conservative treatment and then surgical. So it's unusual to perform surgery earlier than 3 months from the onset of symptoms. And then if we're looking at it in-season athletes, we like to start out with a 4-week trial of rest, steroid or PRP injections to the rectus abdominis and or adductor longus. Allow closed chain lower extremity workouts during that rest period in terms of physical therapy. Now, at the completion of rest, a functional return to sport assessment can be performed to see if an athlete is capable of returning to the season. Playing through pain is usually not believed to worsen the tear. Here, just looking at the rectus abdominis, the origin is the pubic crest, and it inserts into the costal cartilage of the 5th, 6th, and 7th ribs, as well as the xiphoid process. And as with the adductor longus, the origin is along the pubic symphysis and medial to the pubic tubercle. So in terms of surgery, there's 3 surgical options, one being the laparoscopic mesh placement, which involves the transabdominal peritoneal hernia repair and the total extraperitoneal hernia repair. There can also be an open suture repair or an open mesh repair. Variations can include combination open suture repair with mesh onlay, and in any operation with added nerve release and or muscle release. So for the transabdominal peritoneal approach, the peritoneal cavity is entered, a flap of peritoneum is raised in the inguinal region, and a piece of mesh is placed in the preperitoneal space to cover the myopectineal orifice and inguinal region. For the total extraperitoneal approach, the peritoneal cavity is not entered at all. The dissection is started and maintained entirely in the preperitoneal space. The plane is continuously developed into the groin so that the mesh can be appropriately placed in the inguinal region. For open suture repairs, which are actually the most common, and they create stability of the anterior pelvis, which is often accomplished by broadening the rectus abdominis insertion, which creates some degree of tension and reinforcing the posterior inguinal wall. For the open mesh repair, a polypropylene mesh is used, and surgeons prefer a lighter mesh as there is less inflammation and scar tissue. Now, all 3 surgical treatments do have the following in common. They all reinforce the posterior wall, and they help with fixation of the rectus abdominis or rectus and conjoint tendon interface. So here we see on the left side a normal external oblique muscle. There's no tears present. Now here, once it's opened up, you can sort of see tears in the external oblique muscle fibers here. So post-operatively, it's usually like a 10-week course. So the first 1 to 2 weeks, you want the patient to be able to stand upright and walk 20 minutes on day 1, and thereafter walk gently 4 times a day. During weeks 3 and 4, you want to progress to walking for 30 minutes 4 times per day for 4 days, then jog and run gently for the next 3 days. During weeks 5 and 6, the patient should be able to run in straight lines, do gentle sit-ups and adductor exercises. Weeks 7 and 8 should include sprinting in straight lines, increased number of sit-ups, and begin swimming. And then between weeks 9 and 10, we want the patient to be able to kick and play in any sport. So grading sports hernia as well. There's little research about grading, And just speaking of Dr. Troxler, he sort of proposed that there could possibly a grading system that would be split up into 3 grades, 1, 2, and 3, where grade 1 would include posterior inguinal wall weakness. Grade 2 would have conjoint tendon or rectus abdominis tears, and grade 3 being a combination of 1 and 2. So overall, sports hernias are a distinct syndrome of the lower abdomen with groin pain that is found predominantly in high-performance athletes. These athletes tend to have reoccurring pain, more pronounced with certain activities. Conservative treatment includes rest steroids and PRP. And the 3 main surgical repairs include laparoscopic mesh placement, open suture repair, and open mesh repair. And I'll open up the floor to questions.
Thank you, Dr. Singh, for your presentation and the thoughts on the sports hernia. Before I get to the question and answers, I wanted to give your club mentor, Dr. Troxler, an opportunity to share a clinical pearl or a comment.
Excellent presentation on a difficult topic. Sports hernia is probably our equivalent to irritable bowel syndrome. An irritable bowel syndrome, to diagnose it, you have to, it's a diagnosis of exclusion. And so this is kind of the same thing. It's a diagnosis of exclusion. And Dr. Singh took a very difficult topic, assimilated it very well, and presented it probably in the most understandable way that I've ever seen. I've always struggled with this topic. And so unfortunately, a lot of athletes, when they have groin pain, they go see a urologist, and urologists aren't the best people to fix hernias. They have some training. Urologists will fix spermatoceles, which can cause pain, but typically the pain generator is the sports hernia. And so I've seen a lot of people have spermatocele surgery with groin pain, and a year later they still have pain, and it ends up being a sports hernia and end up having to have a second surgery. So in that extensive list Dr. Singh gave at the bottom of the list, it was on there, spermatocele. And so, just like the foot, the boards love sports hernia, and they give you several cases like this to try and throw you off to diagnosing the sports hernia when it's something else. And so very good presentation. This is one presentation you want to keep because you'll run into this a lot. And it's, as you can tell from the presentation, not an easy diagnosis.
Thank you, Dr. Troxler. I know for me, it was interesting learning about the surgical treatment options for a sports hernia. And thank you, Dr. Singh, for presenting that. Moving on to our third presentation for tonight, I want to say Bill Khawaja is here, and his club mentor is Dr. Jonathan Mason. Bill is actually a second-year medical student, so that's why I made a mistake saying doctor, but soon to be doctor at the Chicago College of Osteopathic Medicine, and a part-time ACSM certified personal trainer at Lifetime Fitness, my previous gym. He is a proud recipient of the 2024 AMSSM Gallen Society Student Scholarship. Bill aspires to build a career in primary care sports medicine, combining his medical training with his passion for fitness and wellness. His presentation is on the article, Evaluation and Management of Elbow Tendinopathy, a problem that feels far too common. I would also like to thank Dr. Jonathan Mason for serving as his club mentor. Dr. Mason graduated medical school from Midwestern University, Chicago College of Osteopathic Medicine. He then completed residency at UT Austin Dell Medical School in family medicine with a sports medicine distinction track. He completed his fellowship in primary care sports medicine at Wake Forest. He currently practices family medicine and sports medicine in Austin, Texas. He enjoys golf, cooking, and spending time with his family. And with that being said, I'll pass it on to Bill to make his presentation.
Thank you, Dr. Ibrahim. I appreciate you. All right, guys, I know last presentation, I'm going to try to get us out of here at a respectable time. I don't want to eat up y'all's time. And I have a test in the morning too. So, all right, so let's go ahead. Let's get started here. Can you guys see my screen?
Yes.
Okay, wonderful. Let's get started. So, evaluation and management of elbow tendinopathy. The original article is from 2012. It's been quite a while. A lot of the techniques that we talk about in this presentation kind of are the standard what we expect to see with treatment of any elbow tendinopathy. So I'm going to go ahead and get started here. Learning objectives. I always like to put out learning objectives at the beginning of a PowerPoint. If you guys take away anything from this, kind of these are the things I want you to take home. I want you to understand the diagnosis and treatment of medial and lateral epicondylitis, but also distal biceps and triceps ruptures. I want you to compare conservative and surgical when we're talking about each specific diagnosis. And then, we're going to end talking about some newer treatments like PRP. But then once again, this article came out 12 years ago. PRP was kind of coming on the scene in terms of being available to the general public. 12 years later, PRP is very common. And in fact, there are newer treatments out there like 10X and other things that this article didn't even cover because at the time, those things weren't available. So let's keep talking. So this study was a meta-analysis, and these are kind of the variables that they all looked at. They looked at a plethora of different studies, but they were looking for pretty much a population that showed some type of elbow tendinopathy from those 4 diagnoses that we talked about. And then they compared conservative to non-conservative, which is often surgical. And then they also talked about the outcomes in regards to pain relief, functional recovery, return to activities. Now, because the population was so spread out, I mean, each study had a completely different population. It was a little bit hard to kind of generalize, but they were able to give some general recommendations after the meta-analysis itself. So let's talk about, why this study was important overall. Tendinopathy is a very real thing. I've had both medial epicondylitis and I've had lateral epicondylitis as well in my life personally. It's very common in manual laborers. It's not just an athlete thing. Effective management is key for reducing disability, and prior studies have shown that conservative treatments are pretty good for medial and lateral epicondylitis. But of course, for tendon ruptures, it's a completely different story. So let's keep talking here, all right? So key terms and definitions, I want you guys to just know what I'm talking about as we go through each diagnosis. Lateral epicondylitis is specifically tendinosis of the extensor carpi radialis brevis most of the time. Oftentimes, that is the tendon that's effective, but it can be any of the extensor tendons, but that's the one you're going to see most likely in your office. I will say, do not confuse tendinosis and tendinitis, all right? Tendinitis is an active inflammatory process that's happening in your tendon, and it's still very hot in terms of healing. Tendinosis it's been weeks, it's felt this way. The inflammation process is kind of shut down and gave up. So we kind of have to, that's where PRP and other modalities, even prolotherapy, they're trying to kind of induce that inflammation again. So tendinosis is completely different than tendinitis. Medial epicondylitis is degeneration of the flexor pronator muscles, common in golfers. Distal biceps rupture is a tear of the biceps tendon, and then distal triceps rupture is tear of the triceps tendon. Specifically, look at where they are rupturing. It's distal, so for the biceps, it's the radial tuberosity, and then for the triceps, it's from the olecranon. Let's keep going. So lateral epicondylitis specifically, it affects 1 to 2% of the general population, common to see in tennis players and laborers. Like we talked about tendinosis, this study specifically was looking at tendinosis. It was not looking at tendinitis when they were kind of looking up studies that compared lateral epicondylitis treatment. So right off the bat, conservative treatment is physical therapy, non-steroidal anti-inflammatories, bracing, PRP, corticosteroids. Typically, a sports med doctor will go through all of these before we even talk about surgery potentially, and it takes up to 6 months to a year of trying these different treatments. once again, some of them can be subjective. I've had lateral epicondylitis myself, and I've had medial epicondylitis, and I got PRP done, and it really didn't do anything for me. But this meta-analysis said that PRP looked very promising for lateral epicondylitis. So like that being said, there's no uniform approach with kind of the newer treatments, but PT, non-steroidal anti-inflammatories, bracing, even cortisone, they're pretty good in terms of actually seeing relief and not having to progress further to surgery. So just a cool little MRI from the study itself. You can see that, you know, this is a left elbow, and we're looking at a coronal kind of MRI of it, and you'll see a high-grade proximal tear in the extensor carpi radialis brevis right there. Once again, I'm a second-year medical student. If you showed me these MRIs, I'd be like, what are we looking at? But I'm very happy there's an arrow pointing exactly to where the tear is. But at the same time, MRIs for lateral epicondylitis never happen most of the time. Good luck getting insurance to pay for that. Oftentimes they will send you through PT, tell you to do conservative treatment, you know, do cortisone, PRP, and then maybe they'll do an MRI if it's not healing and they're talking about surgical outcomes. That's why this MRI is cool to see, because the chances of you seeing an MRI with lateral epicondylitis isn't that common. That being said, though, with ultrasound, which once again, this meta-analysis is 12 years old, ultrasound's kind of our new deal, right? It's everywhere. It's in every sports medicine office. You would see physicians be much more inclined to use ultrasound to diagnose something like this in office than order an MRI. So let's keep going. Medial epicondylitis, kind of the lesser, cooler brother of lateral epicondylitis. You don't see it as often, but it does affect athletes and it does affect workers. So it's repetitive stress on the flexor pronator muscles. Same exact stuff right here, you know, PT, NSAIDs, PRP, corticosteroids. With the steroids, you want to be careful if you are near the ulnar nerve. It does get kind of tricky in there. Now, surgery is even less common than it is for lateral epicondylitis, because you'll often have to also do an ulnar nerve decompression just to kind of take that pressure off. But then medial epicondylitis is one that even the study showed that conservative treatment was very, very successful. It's not something you'll typically go to surgery for. Once again, ultrasound, that was not looked at all in this meta-analysis. It wasn't even a factor that was analyzed. This was done in 2012, but ultrasound is gold standard for even looking at some of these things right off the bat. Once again, MRI, it's not going to probably be ordered. It's way too expensive. And that's why this study didn't even have an MRI of medial epicondylitis to share. So yeah, let's talk about a distal biceps rupture. This is rare. You often don't see this. It happens mostly in men aged 40 to 50. I'll tell you right now, oftentimes someone will be doing an eccentric movement of the bicep that'll lead it to rupture. Super common if you have anabolic steroid abuse or a prior rupture. I've seen this personally before in the gym. I've seen one of someone who was at the gym. Once again, I work at Lifetime, clearly on anabolic steroids, doing a very heavy eccentric movement with the bicep. And I saw that bicep tear in front of me, kind of just, it's interesting. When it tears, it'll just squeeze up right there. And it actually is pretty terrifying. I'm not going to lie. But it is pretty, it's rare. You're not going to see it. You have to get the patient into surgery pretty much as soon as possible for having very successful outcomes. The only time you would not do surgery for a distal biceps rupture is if you have a low functioning patient whose strength is already compromised, and putting them through surgery might risk further complications. So the best outcomes that these studies and meta-analysis showed that distal biceps ruptures, you had to do it within 3 to 4 weeks of the injury itself. Here is a cool MRI of a high-grade insertional partial tear of the biceps tendon. What's cool is partial tears really don't happen. It's usually a clean-cut tear. And so there's something very rare. MRIs are much more likely to be ordered for the tendon ruptures because surgery is imminent, and insurance loves to have an MRI that can confirm that you have an actual tear that the physician is going to work on. So very cool to see. Let's go to our final diagnosis here, distal triceps rupture. This is the least common tendon injury. It's often only seen in athletes. I did a case study presentation on this at the Midwestern ACSM. We had a athlete in Greece, a CrossFit athlete who had torn his distal triceps doing once again, a hard eccentric movement. There's something about the eccentric movement and the pressure it places on tendons, specifically for the biceps and the triceps, that let it become more malleable and more just prone to injury. So that's something to keep in mind when we talk about presentation. When you ask your patient, what were you doing exactly? Do you remember? And for that case presentation, that case study that I did do, it was an eccentric movement. Once again, immediate surgery. The quicker you do surgery, the better. Partial tears you will not see usually. Once again, you'll see full tears with tendon ruptures like this. MRI, there it is. You can see this, we had a sagittal kind of view right here. What's interesting is we saw that the tendon tore. If you read right here on the description, it was a pre-existing tendinosis. I will say, you know, when we talked about the tendinosis for lateral epicondylitis, medial epicondylitis, they are a lot less likely to proceed to something like a tendon rupture. We really don't see that, but with biceps and triceps, it's more common. So that's just an interesting kind of correlation there in terms of there was pre-existing tendinosis in this specific MRI of this patient that we saw. And the case study that I presented, the athlete, the CrossFit athlete, also had recorded telling us that he had some lingering tendinosis in his tricep before it eventually tore. If we're talking about anabolic steroids specifically, the reason why you will see this in bodybuilders is because the steroids, specifically usually testosterone, causes muscle mass to grow exponentially. The muscle mass expands at a rate that is far beyond what the tendon is used to. Remember, tendons do not have a highly vascular blood supply. They grow in different methods and different ways. And because of that, the muscles kind of overwhelm the tendons, as the muscles can keep getting hit over and over and regrowing every night or every so, and they get bigger and bigger, and the tendons can't handle the weight and force that the muscles can. And because of that, you start seeing ruptures. So tendon ruptures, if you are going into sports medicine, someone comes in with a tendon rupture, just, you know, of course, you might be able to tell based on the patient size and who the patient is, but just to keep in the back of your mind, anabolic steroids are pretty common for these kind of things. All right, so summary of the treatments analyzed, you know, epicondylitis, like we talked about, conservative management works for most, surgery for refractory cases. When we talk about the epicondylitis, you know, conservative treatments, we're talking about physical therapy. We're talking about NSAIDs, non-steroidal anti-inflammatories, PT, cortisone, PRP, anything that doesn't require us to go under the knife, okay? And usually epicondylitis usually heals up pretty well with conservative management. For the biceps and triceps ruptures, you have to do surgery. You have to literally attach the tendon. If you don't, you know, the functionality of the actual muscle might be compromised for the patient in their everyday life. So let's talk a little bit about discussion, because I kept telling you guys about how old this study is. The populations that we were looking at were inconsistent, and there were very limited randomized trials. Often it was just, you know, one group or two groups that were given kind of, you know, they both knew exactly what they were getting into. Because of the inconsistency in study populations, it's possible that still to this day, some people, their response to conservative treatments might not be as great as we think. There was a lack of strong randomization or blinding, so that affects our evidence quality. Like I said, most people knew exactly what study they were in and what group were they part of. For follow-up, you know, conservative treatment takes 6 to 12 months. A lot of people, after 6 months, told on the surveys that, hey, I feel great. We really don't know what happened after 12 months or after that. There was very limited long-term data for PRP when this meta-analysis came out. 10 years later, I'm sure PRP is a lot more expanded. But like I said, there's new treatments out there too with 10X and other things that people do in office that possibly could show even greater like success rates. Outcome assessment, recovery and return to activity are often subjective too. We can ask you like, are you able to do daily house chores? Yes. But then also, are you able to lift 60 pounds? Completely different things. And they were subjective in their questioning too. Oftentimes when you're doing a meta-analysis, it's hard to find data where every population and every survey, every measure is the exact same. But this one, it was 2012, and they really did not have uniformity across the board when kind of doing all these comparisons. So key points, things I want you guys to just take home for epicondylitis, conservative treatment is first line. About 10% of people might need surgery, but that's after 6 to 12 months of nothing kind of shaking here. For biceps and triceps ruptures, if you suspect that your patient has a bicep or tricep rupture, they need to get into surgery immediately. Early surgery leads to better recovery of strength. That case study we did where a guy, his complete tricep tendon had ruptured, he got into surgery within 2 weeks, and he is 100% A-OK today. He's lifting just as much as he was lifting. It just shows you have to work quick, though. Functionality can be compromised if you wait too long. Clinical application, some of the things we just talked about. PRP with the meta-analysis looked promising. It did show very good data in one study for lateral epicondylitis, but once again, it was 2012. A lot has changed since then. I'll tell you my own anecdotal case. I've gotten PRP done right in my lateral epicondyle. It really didn't do anything for me. And so, but that's just one anecdotal case. Future research, if someone else does decide to do a meta-analysis on these 4 diagnoses of the elbow and kind of the general arm, there is a need for PRP and corticosteroid comparison with randomized controlled trials. Now, I'll say the good news is I went to the AMSSM last year, the meeting. There was studies that have been done comparing PRP and cortisone injections, and they actually showed it at one of the presentations. Sadly, both of them were seen equally as effective. So the PRP or corticosteroid, they were shown as the exact same in a randomized controlled trial. Newer treatments on the kind of horizon, biologics, regenerative medicine. Like I said, there's new stuff out there. 10x is the one I know that's kind of really gotten popular in the last few years with private clinics and smaller clinics. There needs to be better long-term outcomes for data. We do know in 6 to 12 months how people feel, but for tendon ruptures, there is very limited data, at least from this meta-analysis, in terms of did that tendon ever rupture again? Was the patient okay? Or, were they able to keep their functionality up at a high level for prolonged periods of time? All right, and that is my presentation. I want to thank Dr. Jonathan Mason for being a cool mentor to me. He went to my medical school. He did a good job of kind of guiding me through this process, and I appreciate you, sir.
Thank you, Bill, for sharing that presentation on the elbow with us. And I did want to give your mentor, Dr. Mason, an opportunity to share a clinical pearl or a comment with the group.
Yeah, nice job, Bill. Great job. Thank you very much for that wonderful presentation. Thank you for also shining some light on the fact that this article was published in 2012. I would like to add that it was published by 2 orthopedic surgeons, and I think it's very valuable to put ourselves in their shoes for what the treatment options might be. But as many of us know who are non-operative, that there's some other treatment options that are out there. You mentioned 10x. There's definitely been some research over the past few years looking at PRP or other ultrasound-guided percutaneous tenotomy or fenestration or prolotherapy that seems to be really beneficial. And so it just depends on the clinic that you're working in. But if you're working in an strictly orthopedic clinic and you're not doing these types of procedures, then maybe you would see somebody in like 6 to 12 months for surgery. But honestly, in a non-operative clinic, we probably wouldn't send somebody to surgery at the 6-month mark like they recommended in the paper. We would probably try more conservative measures first. The other thing is that it certainly can be beneficial to throw the ultrasound on there to see if there's an area of hypoechoic thickening that could be suggestive of tendinosis. If you throw your ultrasound on there and that is not there, then you might want to start thinking about other things like an OCD in the elbow where an MRI would be valuable. So I do think that the ultrasound is a wonderful screening tool to help confirm your diagnosis as well. But great job, Bill. Thank you very much.
Thank you, Dr. Mason, and thank you, Bill. Good luck on your exam tomorrow. I'd like to thank all three of our presenters, Dr. Young-Hyu, Dr. Jasbir Singh, and Dr. Bill Khawaja for their outstanding presentations. And I would also like to thank their club mentors, Dr. Stokes, Dr. Troxler, and Dr. Singh. And Dr. Mason, excuse me. I'd like to thank everyone for joining tonight. It was a pleasure serving as the club advisor and moderating tonight's Journal Club meeting. I'm also pleased to announce that our next AMSSM Journal Club meeting will be held Thursday, October 24th at 9 p.m. Eastern Time. I hope you make plans to join us and mark that in your calendar. Most importantly, I would like to thank, one of the most important things, I'd like to thank Joan Brown for setting up this amazing group tonight and these amazing presentations. It would not be possible without you. With that being said, thank you for joining us tonight. Have a good evening and good night, everyone.